Thank you, Professor, for talking to us today. So as I said, I'll start with a very general question. What are the main causes of suicide?
There are many, many causes of suicide. The first thing that we assume is that the person had a mental illness. So the question then becomes what kind of mental illness, and some disorders have more suicides than others. For example, schizophrenia has a 10% risk of suicide. The diagnosis of bipolar disorder has a 25% risk of suicide. So certain illnesses are more associated with suicide than others. But it's not simply enough to have a mental illness. You then have to look at so many other factors in the person's life. We really
Which ones?
don't have time to go into all of them, but I can give you some examples. Substance abuse. So individuals who use alcohol to excess. Individuals who are addicted to cocaine, to heroin, to illegal drugs of one kind or another are more likely to commit suicide. Individuals who have had a particular stress, such as the loss of a loved one, the loss of a job, that kind of thing is going to increase the suicidal risk. So it's mental illness plus a number of other factors that have been fairly well documented. And the more risk factors you have, the more likely you are. Probably the best predictor, if you want to say something about prediction, is a prior suicide attempt. So a person who has made a suicide attempt, within the next year, about 30% of them will make another suicide attempt. So 1/3 of those who made a suicide attempt are going to make another suicide attempt, and 10% of those are going to be successful. So when you hear of a person who's made a suicide attempt, that is a very good predictor of at least another suicide attempt, and you have to be very, very cautious.
Today I've heard of chemical biomarkers or something very odd, which is called electrodermal hyperactivity, which are quite, biological, organic. So what do you make of this?
This is where most of the research is happening right now, to look for a biomarker, as it's called. And there are some studies that indicate there are changes in the body chemistry of people who have mental illness, not necessarily people who are suicidal. So I mentioned bipolar disorder. There are certain biochemical markers that go along with bipolar disorder. There are certain chemical markers that go along with schizophrenia. So if you look at these biomarkers, they may give you a hint that suicide may occur. The electrodermal activity that you talked about is really a very simple concept. It's how the skin is reacting to stress. So if somebody is under stress, under more stress, again, that's a risk factor. So if you want to determine whether there's stress, you can look at some of these markers, such as skin resistance.
Thank you. Which is the best approach, if there is a best approach, to prevent suicide or the suicidal risk?
I think the best prevention is having access to a mental health professional. In other words, if the person is having suicidal thoughts, these are individuals who are in distress to begin with. If there's some place they can go to talk about it, if there's a suicide hotline, for example, using the telephone, if there's for example, I direct student mental health at our medical school. All our students know that if they have any distress, they can talk to a psychiatrist 24 hours a day. All they have to do is call a certain number that they have. So the best prevention is going to be access to a mental health professional so the person can talk about their feelings.
It is more a sort of psychological, psychotherapeutic approach, relationship, medical physician. It is more like getting some drugs. So
now, I think, are you talking about treatment rather than prevention? The treatment is multivariate. I mean, there are so many approaches. One is medication. Again, you have to determine what the mental disorder is. So some mental disorders are going to respond to one medication as opposed to another. Medication is very, very important. What is underestimated, though, is the doctor-patient relationship. If you can establish a doctor-patient relationship, which means psychotherapy, not simply giving medication, that's not enough. You have to establish a relationship with the patient, a trusting relationship with the patient, so that patient knows that should they develop a suicidal impulse, you're available. There's nothing more reassuring than for a doctor to say, I am going to be with you until you get better.
You said that 50-75% of American psychiatrists had patients that commit suicide. Is that correct?
Yes. And that's simply a function of the degree of illness that these psychiatrists are treating. So the psychiatrists that are most likely to experience a patient suicide are those who are working with bipolar disorder, schizophrenic disorder. These are the ones who are most likely to have suicides. Not because they don't give good treatment, but there's a natural evolution in certain disorders, and given the present state of our knowledge, we cannot stop some individuals from deteriorating.
You think that the physician, because you said that physicians, shock, disbelief, grief, and then anger. Is this just because they've lost the patient, or because they feel they have a sort of responsibility in this?
I think it's both. I think they feel a responsibility. Every doctor feels a responsibility. Every doctor, regardless of specialty, grieves when a patient of theirs dies. That's a truism, I think, in medicine. That we become attached to our patients. We try to do the best. If that patient dies, we do grieve. And that's normal. There's nothing wrong with that. What I emphasized in my talk about psychiatrists feel guilty. Psychiatrists feel that they made a failure, even though they may have done the best that they could. So the question is, why do psychiatrists react with guilt, feelings of being unworthy, feelings of being failure, when an oncologist, for example, who treats cancer patients, who grieves when their patients die, but they don't think they have been a failure? Assuming the psychiatrist has done the best that he or she can, assuming the oncologist has done the best he or she can, why does a psychiatrist feel guilty? I think the psychiatrist feels guilty because we're training them in the wrong way. We're training them that they should be able to save every patient.
Which is not possible.
Which is not possible in medicine, regardless of specialty.
Can you tell which patients can be saved and which not?
I don't think we can predict that. We can't predict that.
Is it a success to sort of extend the life of a patient with a severe mental disease, potentially,
I think that's exactly the point. The same way that an oncologist extends the life of a cancer patient through chemotherapy, through surgery, and we give the patient years of life even though they have a fatal disease, cancer of a particular organ that we know is fatal. Yes, some cancers can be cured, but not all. I use that analogy a lot because in psychiatry we have a similar situation. There are some disorders that we cannot yet cure, that have a downward course. And if we can start to accept that, it's very hard for doctors to accept that their patients are going to die regardless of what they do. Doctors have a hard time with this. Doctors want to save lives. There's an aphorism in medicine that no doctor saves a life. All that doctor does is postpone a death. Humbling thought.
And question about this thinking that you've just said. I mean, is it correct to say to a patient affected by severe depression that, his disease, his mental disease, is just like a liver cancer? And
I think I wouldn't necessarily want to equate it with cancer dealing with the patient, but I certainly would say to a patient that this disease is associated with a risk of suicide. And unless you do X, Y, or Z, you're liable to die from suicide. In the same way we say to a patient, if you continue to smoke, you're likely to get lung cancer. You already have lung disease. If you continue to smoke, you're going to get worse. And I think we have to say this to mental patients as well. If you continue to follow this activity, such as using drugs, using alcohol, you're going to die from it.
so sorry, I don't know whether I understood it correctly. Can we say that in that perspective, suicide is a sort of symptom of something, of a severe mental disease, is a symptom to be kept under control with all the means that you have available?
I think that's a fair assessment, yes. It is a symptom to be under control, although some people now are beginning to study the genetic background of people who kill themselves, where suicide may no longer be a symptom, but suicide may be a disease.
Do you believe it's possible?
I don't know.
When do you think this outcome will come out?
I have no idea. I think we'll continue to study. It's like asking me when cancer will be cured.
Do you think that severe mental disease patients are somehow doomed to die? For example, those with bipolar disorders, with schizophrenia.
I would never say anybody is doomed to die. I think we can and do try to do everything we can to extend life. Can we say theoretically that some bipolar patients may be doomed to die? Perhaps. But they also may be destined to live with proper help.
Putting the last question, putting the things in the other way, when do you think we can talk of curability of the mental disease? Meaning that patients get back to, being cured, not just with symptoms under control.
I've been in practice for 50 years. And I can say that we probably know as little, and I'll use schizophrenia as an example. We still do not know the cause of schizophrenia. We still not are able to cure schizophrenia. And that's 50 years. So if you ask me, will we know more in another 50 years? I hope so. But this is what all the research is about. This is where we're putting our clinical research, biochemical research, and I think eventually a cure will be found. Right now we're studying the brain, and these are brain diseases. And I think the brain is probably the most complex organ we have. To the extent that we understand it, that's to the extent that we'll be able to cure.
Thank you, Professor. Thank you.